Hello everyone. Today we are going to discuss on drain care.
Definition: a device such as a tube inserted intraoperatively into a body cavity or opening of a surgical wound to facilitate discharge of fluid from body. A surgical drain is a tube used to remove pus, blood or other fluids from a wound. It's used for a short period of time. Indications for drain are to prevent accumulation of fluids such as blood, pus and infected fluids, to prevent accumulation of air in the dead spaces, to characterize fluid, decrease infection rate. Specific examples for drain and operations are breast surgery, orthopedic surgery, chest surgery, infected cyst, pancreatic surgery to drain secretions, biliary surgery, neurosurgery, etc. Drain system consists of plastic tubes with perforation to allow fluid to drain from the surgical wound site. The drainage is collected in any form such as a closed sterile collection system or reservoir or an open drain system that deposits the drainage on a sterile dressing. Penrose are used commonly as open drainage system for wound care, and absorbent dressing is applied to the area to collect drainage and to keep the area dry. It uses a small plastic tube that collapses easily and has a safety pin or clip attached to keep it in place. These are some examples of Penrose drain. Closed drain system. The drainage is collected in a closed sterile collection system or reservoir. The examples of closed drain system are Redivac, Hemovac and Jackson-Pratt drain. The parts of the Jackson-Pratt drain are tubing, emptying cap, emptying pot and collection reservoir. Closed drains can be active drains or the passive drains. The active drains or closed suction drain combine gravity drainage with active suction created by the drainage system, usually used in the subcutaneous tissue after the breast, abdominal, plastic and orthopedic surgery to prevent blood or serous fluid collection. Examples are Redivac and Hemovac. Whereas the passive drains or the closed non-suction drain works by gravity, capillary action or combination of these. Commonly used after the abdominal or the pelvic surgery. Examples such as Robinson's drain. Complications of drains are infection at the site of drain tubing, pain and discomfort to the patient, blockage in the tubing of the drainage system, poor draining, erosion of the tubes. Nursing considerations to monitor for the signs of sepsis. If the patient is febrile with the drain, has redness on the skin or at the site of tubing, tenderness at the site of tube insertion, bad odor from the dressing or the drain, drainage with pus or increased ooze at the drain site, this could be a sign of infection. The treating team must notify and blood culture may need to be obtained. Drain patency should be monitored. Insertion site should be observed for any signs of leakage, redness or signs of oozing at the beginning of your shift and before and after moving a patient. If applicable, ensure suction is maintained. A blocked drain tube can lead to formation of hematoma and increased pain and risk of infection. Monitor drainage. Drainage need to be documented as accurate every 24 hours but a minimum 4 hourly and more frequently if output is high. Normally, the drainage in the bulb is red after the surgery, then it becomes less red over time, usually becomes clear yellow with occasional small blood clots, and this is normal because of the healing process. Note: notify physician if the drainage becomes bright red with clots or milky white. measure more than the expected output mentioned by the doctor within 24 hours. Milky white output chyle. It's a lymphatic fluid. Chyle accumulates in the pleural cavity because of leakage from the lymphatic vessels. It is most commonly seen after the thoracic surgery. Drains should be removed as soon as practicable. The longer a drain remains in situ, the higher risk of infection, as well as development of granulation tissue around the drain site, causing increased pain and trauma upon removal. Pain assessment tools should be used to complete the documentation at regular intervals whilst drain is in situ. Appropriate analgesia should be provided when necessary. Examples of pain assessment tools are PIPP, FLACC, Wong-Baker's numeric rating scale, behavioral pain scale. Assure that reservoir hangs lower than the wound to allow gravity to facilitate wound. If a patient has more than one drain, each one should be numbered to prevent confusion. Example 1, 2, right, left, etc. Drain should firmly secured at the exit side, example with the sutures, and if attached to a drainage bag or bottle, they should also be secured at one another point, example with the adhesive tapes. Drainage bags should not be placed on the floor to minimize the risk of cross-infection. Nurse-patient education. Educate the patient to ensure the drain is below the site of insertion but not pulling on the patient. There is a risk of dislodgement requiring increased care when moving. Educate the patient should be aware that moving whilst drain is in situ will cause some pain, but this can be minimized with regular analgesia, and the patient should be encouraged to mobilize with supervision when appropriate. Educate to not take bath earlier than 48 hours or submerge incision or any part of the drain system in water. Emptying a closed drain system. Verify physician order. Physician should specify an amount for acceptable drainage for the drain to be removed. If there is any plan for drain removal, gather all the materials and equipments, trolley or other suitable surface to place all the equipments, sterile fluid for cleaning, example sodium chloride 0.9%, gloves, one disposable pair and one sterile pair, alcohol, hand rub, dressing pack, sterile gauze, Galport, disposable bag, sterile towel for dressing, hypoallergic tape. Optionals are sterile scissors, forceps, culture swab. Identify patient correctly by the three names of the patient. Explain the procedure to the patient that the procedure may be uncomfortable to the patient. Perform 5 movements of hand hygiene. Provide privacy. It gains the cooperation of the patient. Wear appropriate personal protective equipments, the sterile gloves and the clean gloves. Observe aseptic techniques throughout the procedure to prevent infection to the patient. Prepare and position patient appropriately depending upon the site of tube inserted. Monitoring the patient with the drain is very essential. Assess incision and drain entry site. Ensure the tube is free from kinks, twists and leaks. Monitor the amount, color and types of drain. Notify the physician if there is any unexpected changes with the drain. Jackson Pratt is a closed drain system consists of a clear plastic tubing sutured to skin and a bulb. A bulb helps in collecting the drain. The bulb applies constant suction pressure which pulls excess fluid out of the body. To empty the Jackson Pratt, first of all we have to gently squeeze the tube between the thumb and index finger, moving fingers along the tubing towards the suction bottle to help dislodge any obstruction or blood clot. Can use the soap, liquid sanitizers to help fingers to glide over the tubing easily. Then pull the stopper out of the bulb to empty the bulb. We can collect the drain in a clean cup. The exact amount of the drain should be documented in the intake and output chart. Then the drain can be discarded. To re-establish the suction pressure, first squeeze the bulb in palm of the hand into inside wall of the bulb should touch. While maintaining pressure, we place the plug close it tightly. Slowly release the grip to re-establish suction. The bulb should remain concave or somewhat flat. It should not be fully inflated. If bulb is not flat, suction is not maintaining. If dressing is needed, such as soak dressing, oozing at the site of drain, or it's due time for the dressing, then always remember to note offer the patient analgesia as prescribed or indicated and allow appropriate time for medication to take effect, because the drain site will be very sensitive to pain to the patient.
Before changing a dressing, perform hand hygiene and ensure the patient's privacy. Introduce yourself. Verify the patient's identity using 2 identifiers.
Can you tell me your name?
Gary Fulton,
Okay. And your birth date?
6/14/1954.
Okay.
As you explain the dressing change process to the patient, assess his pain level. Check that the prescribed analgesic administered 30 minutes prior has taken effect. Put on a gown and goggles if there's a risk of spray. Position the patient comfortably and drape him so that only the wound site is exposed. Instruct him not to touch the wound or the sterile supplies. Place a disposable biohazard bag within reach of your work area. Fold down the top of the bag to form a cuff. Apply clean gloves. Now you're ready to take off the old dressing. Remove the tape by pulling it parallel to the skin toward the dressing, holding down the uninjured skin. Be sure to pull in the direction of any hair growth. If necessary, obtain the patient's permission to clip or shave the area according to your agency's policy. Remove the old dressing 1 layer at a time with your clean gloved hand or with forceps. Observe the appearance of the drainage as you proceed. Carefully discard the outer secondary dressing first, followed by the inner primary dressing, the layer that's in contact with the wound. If any drainage devices have been placed, avoid putting tension on them by slowly lifting away the layers of the dressing. Keep the soiled undersurface of the dressings concealed from the patient's view as you work. Fold the dressing to contain the drainage. Peel off your gloves inside out and perform hand hygiene. Apply another pair of clean gloves and assess the wound.
Okay, now I'm just going to assess your wound.
Refer to the video skill Assessing Wounds for details. Then dispose of your gloves in the waterproof biohazard bag and perform hand hygiene. Now create a sterile field by placing a sterile dressing tray or individually wrapped sterile supplies on the overbed table. If a sterile solution has been prescribed, pour it into the sterile gauze. Depending on your agency's policy, you may put on sterile gloves to provide wound care, or you may use a no-touch technique, which calls for wearing clean gloves to hold sterile forceps. If you use antiseptic swabs to cleanse the wound, use a new swab with every stroke, or simply spray the wound surface with antiseptic. As you cleanse the wound, work from the area of least contamination to the area of most contamination. If the patient has a drain, cleanse around it using circular strokes. Begin near the drain and move outward away from the insertion site. Blot the wound dry with gauze, holding it either with forceps or in your fingers while wearing sterile gloves, whichever technique you use to cleanse the wound. If ordered, use a similar technique to apply antiseptic ointment.
Now that your wound is clean, now I'm going to dress your wound.
To apply a dry dressing, use loosely woven gauze as a contact layer. If the wound has a drain, place a pre-cut 4x4 gauze pad so that it sits flat around the drain. Apply additional layers of gauze as needed. On top of this, apply a thicker woven pad, such as a Surgipad or abdominal dressing.
Nurse's responsibility in documentation: the type of drain to be documented, insertion site and assessment, amount, color, viscosity of drain to be documented, patient response, pain level and interventions by the use of pain assessment tool to be assessed, charting on the intake and output chart, complete the total output to be documented. Removal of the drain tube: generally drains should be removed once the drainage has stopped or became less than about 25 ml per day. So we have discussed on the drain care. Hope the presentation was informative. Thanks for being part of this presentation.